good afternoon and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome back to yet another episode of very educative lectures for you at the ACNS webinars. The speaker for the first session of today is our special guest from UAE, Professor Florian Roser. Professor Roser is the chair of Neurological Institute at the Cleveland Clinic, Abu Dhabi. He was previously vice chair and chief of staff of the Department of Neurosurgery at the University of Tübingen, Germany. He completed his residency in the prestigious Department of Neurosurgery, Hanover, Germany, and he holds the position of full professor of neurosurgery at the Faculty of Medicine at Eberhard Karls University of Tübingen, Germany, and he also serves as professor of surgery at the Cleveland Clinic Lerner College of Medicine at the Case Western Reserve University, Ohio, USA. He is also an adjunct professor at the Biomedical Engineering Faculty at the Khalifa University, Abu Dhabi. Professor Roser has performed more than 1,900 spine surgeries and 2,500 intracranial surgeries, with his main interest being in skull base and spinal cord procedures. He is the editor-in-chief of the journal Clinical Neurology and Neurosurgery and associate editor for World Neurosurgery. He has authored over 107 peer-reviewed articles, 18 book chapters, mainly as first or senior author, and presented 160 lectures and 67 posters worldwide. We are extremely honored to have him today at our webinars, and today he'll be talking about a very interesting topic, the 200 steps for successful vestibular Schwannoma surgery. The speaker for the second session of today is our honored guest from the USA, Professor Andrew Reisner. Professor Reisner is a pediatric neurosurgeon at the Children's Healthcare of Atlanta and assistant professor of neurological surgery in the Department of Neurosurgery at the Emory University School of Medicine. Dr. Reisner joined Children's in 1999 and currently serves as Elaine and John C. Carlos Chair for Neurotrauma, as well as the Medical Director of Neurotrauma and Concussion. He is the current chair of the Neurotraumatology Committee of the WFNS. He has completed his neurosurgery residency at Emory University School of Medicine, followed by his fellowship training at the Pediatric Neurosurgery at the University of California, San Francisco School of Medicine. Professor Reisner's research interests include traumatic brain injury, concussion, and severe TBI, brain tumors, radiosurgery, and intracranial bleeds in children. He is a noted author with several publications in various peer-reviewed journals and also an invited faculty to workshops and conferences worldwide. He was accredited with several awards and honors, including the very recent the Children's Care Network Award for Merit for Significant Contribution to Pediatrics in 2020. We are extremely honored to have him today at our webinars, and today he'll be talking about Translational Neurotrauma Program at the Children's Healthcare of Atlanta from bench to bedside. The chair for the first session of today is our honored guest from Japan, Professor Michihiro Kono. Professor Kono is the chairman in the Department of Neurosurgery, Tokyo Medical University, Tokyo, Japan. Professor Kono reserves his specialty in skull base and CP angle tumors and holds the record for the highest number of operated cases of vestibular Schwannoma in the world. He is an integral part of the Japanese Neurosurgical Society and also has been an integral part of the ACNS as well as other academically active education societies. He is an invited faculty to workshops and conferences worldwide. We are extremely thankful to him for accepting our invitation to chair the session of Professor Florian Roser. The chair for the second session of today's webinar is our honored guest from Pakistan, Professor Tariq Khan. Professor Khan is the Dean of Northwestern School of Medicine located in Peshawar, Pakistan, and Professor and Head of Department of Neurosurgery at the Northwest General Hospital and Research Center. Dr. Khan was the previous chairman of the Neurotraumatology Committee of the WFNS and is also the chairman of Alliances Healthcare Limited, Pakistan. Dr. Khan is a member of Neurotrauma Committee and faculty of the Asian Australasian Society of Neurological Surgeons, as well as the Medical and Dental Academic Board, Pakistan, and he is a convener for Neurotrauma Committee of the Pakistan. He is also the Dean of Faculty and Examiner for Neurosurgery College of Physicians and Surgeons of Pakistan, and he previously served as the President of the Pakistan Society of Neurosurgeons. We are extremely grateful to him for accepting our invitation to chair the session of Professor Andrew Reisner. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. Dr. Liu Boon Singh from Malaysia is my co-host for today. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this on the WeChat channel. With that introduction, I would like to hand over this online podium to our first chair, Professor Michihiro Kono.
Hi, everyone. I'm Professor Kono from Tokyo, Japan. I am very happy to chair Professor Rose's lecture. He will talk about the 200, 200 steps for successful vestibular Schwannoma surgery. So can we actually remember 200 steps or not? But so we would like to listen to his lecture. Professor Roser, could you please?
Yeah, I will. So thank you very much. I feel very honored to be part of this pretty renowned webinar series from the ACNS. And it's pretty much visible on the social media. So on and off, I had a peek in, and I'm very pleased to see how much education is happening around the world. And in that part, the pandemic really helped us to move forward. So I'm happy to contribute today the 200 steps, and I can assure you, most of them you should remember, some of them you will always include because it's just a natural progression. Okay, I have no disclosures for that talk today. And let me start at the beginning. So as you heard from my CV, so I was the last resident from Majid Sami in Hanover. And as you know, right, the vestibular schwannoma surgery, especially specifically in the semi-sitting position, is something he did on a daily basis. So if you start as a first-year resident, this is your daily business, right? And you take all these steps, everything, you take it for granted. Everything he's doing is so natural, you take it for granted. But you never break it down into these individual steps. And you never ask him, why are you doing it that way you're doing it? So when I moved outside Germany to build up the Cleveland Clinic in Abu Dhabi, which was a greenfield project in 2013, I was tasked to build up a quaternary healthcare center based on the highest levels of care, and to bring the same standard of care and the same level of quality into that hospital. So I assembled a team of like 8 neurosurgeons from across the globe, right? Some Europeans, some from the United States and South America, and a lot of nurses with different various backgrounds. So, and we come from different places and we have different cultures and different backgrounds, right? So everybody has his preferences, and especially specifically in the United States, you work with preference cards and not with procedure cards. But to have a standard of care and to have a good safety measures, and for educational reasons, if you have to bring a global team together, you create a procedure card. And that's actually what we did. We created a procedure card for posterior fossa surgery in semi-sitting position. And that included a lot of these steps, as you outlined in this protocol, with the equipment parts, the consumables, and then all the steps, what you need to do. And what I figured out is when you really break it down, that many things you did over the last 20 years you might not need, but some other things are so crucial. So if you miss them, you might not be as successful as it is. Because when Majid Sami always said, and it might sound arrogant, but he always said, I make it look easy. When he did a very difficult case, I just make it look easy. Why did it look so easy? Because he was observing and following each of these steps. He's done thousands of times, and he never forget any of these steps. He never skipped any of these steps, even if it was late at night, very tired, the third acoustic on that day. He never skipped any of these steps. So that was my baseline, and this is why we broke down many of these steps into 200, right? Of this simple surgery we do. And of course, we're not going to talk about 200 steps today. Some of the red ones I lined up here, we're going to talk about because I believe they have a good learning effect, and they might not be appealing to anyone at first, but then later on, it just makes sense that this is another important step to proceed with this very complex surgery like we do. So this is a paper which is going to be published very soon. It's actually just submitted right now. And I just want to give you some glimpses of these steps. So it's not 200, it's 197, but just leave it like this. Okay. So now the first after the important part is not only the MRI imaging, it is for me, it's the CT imaging. And the CT imaging, because we do it in the semi-sitting position, should be a spiral CT scan with at least 1 millimeter, because you might miss the emissary veins. You might miss the emissary veins, which are so important to detect before you open them up. So it's inevitable that you open them up if you have to dissect the muscles, but you need to know where they are, that you're ahead of the game and you don't have air embolism, air entry, when you do this in the sitting position. So the spiral CT is important for detecting the emissary veins, but not only that. So we look at the CT scan at many other features, such as the pneumatization of the bone, so that you really can see the borders of your lateral craniotomy. Like, where does the pneumatization start? So you can see the pneumatization with convex. You need to see whether, when you drill the internal auditory canal, whether there is pneumatization, so you have to make sure you seal it afterwards. You want to see the laterals, the lateral semicircular canal, because you should not drill that open, because you can lose hearing if you drill open the semicircular canal. You should also not drill open the endolymphatic duct, because that can lose hearing because you had an endolymphatic hydrops. So we also look for the high jugular bulb, right, which can be present in some of those cases, because in that reason, that would be a contraindication for sitting position or for the surgery at all. For example, if it's a small vestibular schwannoma where you have alternative treatment options. So all these bony and osseous details have to be looked and studied in detail prior surgery. And this is why I wanted to mention it here in this number 2 of all these steps. And that has been published a couple of years ago by our group. So the next step I want to talk about is, when you do this surgery in the sitting position, of course, you need a transesophageal echo at all times. And our neuroanesthesiologists, they're placing 2 central lines, and one of them is placed actually in the atrium of the right heart to have a potential for air aspiration in case there's air entry from open venous, from sinus, or intraoperatively or intradurally, for example, from the Dandy's vein, from the superior petrosal vein, or even from tumor veins. So there need to be a transesophageal echo, and so our team prefers to have 2 central lines for air aspiration. And it needs to be a very good communication between the anesthesia team and the neurosurgical team, because they need to do the bilateral jugular compression at any time when there is air bubbles visible in the atrium, or when I, as a surgeon, know I'm going to open up the emissary vein now, and you ask them to do the jugular compression to increase the intracranial venous pressure, so that you can do this, the opening of the emissary vein, for example, under positive pressure, and you don't have air entry at all. Next step is the question of the nimodipine infusion. There was this multi-center randomized study in Germany a couple of years ago where we participated, where we thought, does nimodipine give us a protection against hearing loss, right? And this was very hard to, a very difficult setup, actually, a prospective study to look at similar size vestibular schwannoma, good hearing pre-op, same experience of the surgeon, and then a randomized group of patients received nimodipine infusion prior surgery already, with a central line placed the day before, and they get already nimodipine infusion and during surgery, and the other group is a standard procedure. And yes, there was a statistically significant preservation rate of hearing in this nimodipine group. Well, what I changed the protocol a little bit is that if patients have very good hearing and the acoustic evoked potentials are unstable with a prolonged latency, for example, decreased amplitude, then I started nimodipine infusion during the surgery. I don't place the central line the day before. That's not adequate anymore. I can't admit a patient the day before with a central line for that. But we do this intraoperatively. So not only we do the nimodipine infusion, but we also do irrigation with papaverine, just to avoid vasospasm on the vascular supply to the nerves. I will show you details later. So in large vestibular schwannoma, we do not only the standard electrophysiology, which is SSCP, MEP, facial MEPs, and facial EMGs, and acoustic evoked potentials, but also the lower cranial nerves, which are very important to monitor. If you have a T4 vestibular schwannoma, then we use, for example, the special tube for the laryngeal nerves, which is the tense nerve monitoring, and then we place 2 electrodes in the soft palate for the glossopharyngeal nerve. So this is very important that you consider those steps in patients who have very large vestibular schwannomas. We use hook electrodes so they don't slide out with the saliva, they have a hook. So that's why it should be placed by the physician after placement of the endotracheal tube, and before placement of the transesophageal echo. Our neuroanesthesiologist also place an EEG electrode to make sure the patient is in burst suppression, right? And of course, if you do electrophysiology, it has to be TBI anesthesia with no muscle relaxant. Now, the semi-sitting position is always considered very difficult and dangerous, but if you do this on a daily basis, everybody loves it. And trust me, I convinced my American colleagues who are all the neuroanesthesia is US trained, they love it because you can have very obese patient and it's a very straightforward positioning. As you can see here, this is fast forward, but in real time, it's 3.5 minutes for positioning. Every team member has a spot. The arms are very relaxed. The chest for ventilation is actually much better for the anesthesiologist. The TEE is much better visualized than in the lateral position. So this is very straightforward and a very safe procedure. I also do the semi-sitting position patient with an open foramen ovale detected in TEE. It's just so we are more aware and more conservative in terms of jugular compression. We do this much more frequently, but it's not a contraindication anymore. So now you see here that the arms, the plexus, the brachial plexus need to be very relaxed. You need to make sure that all the extremities are padded and that the legs don't touch the bar and the shoulder doesn't touch the bar. And what we also look at is that the electrophysiology, that they bundle their cables because this decreases the electromagnetic interference in the room. So they're all bundling the cables together in a string and not fluttering around the table. That decreases the interference and the noise. Now, when we look at the head position, this is very important. So there's 4 steps, and I outlined it here. And this is extension first, and then translation, rotation, and anteflexion. You have to have in mind the position of the temporal bone in the posterior fossa. You want to bring the temporal bone in a straight position that you look along with your microscope, that you don't have to rotate your head and your angle of view with a microscope. You want to have a straight avenue along the ridge of the posterior fossa. This is why you have to rotate and anteflect the head in a way that you look along the petrous ridge. And for the internal auditory canal, you rotate the microscope a little bit medial. And for tumor extending to the brainstem or compressing the brainstem, then you rotate the microscope to look to the medial surface. But you have to bring the temporal bone into a very straight position that you can look all along this way. This is even more important if you have petroclival meningiomas or even suprameatal into Meckel's cave extending meningiomas, where you have to drill open the Meckel's cave from posterior and open the tentorium that you can remove supratentorial parts. So you want to look straight along the petrous ridge. This is why you have to do the rotation and anteflexion. And basically the extension is important, that you relax the cervical canal, the cervical spine for this rotation and anteflexion. Now, then after positioning, you do the marking, which is always, I always mark the junction of the transverse sinus and the sigmoid sinus. I just put some points, you feel it with your fingers of the mastoid tip, and then you outline your craniotomy in that sinus angle, and then put a mildly oblique incision around the center of the intended craniotomy. And to double check, the incision should always be 2/3 behind the ear, 2 fingers behind the ears. And if you divide the ear into thirds, the upper third is always the level of the transverse sinus. So this is for me always to double check the correct position of the incision. And then we coming to the next step. So now that's the magic tool, and and that makes the big difference. So we can discuss about sitting position or not sitting position, but if you do sitting position, you have to have this magic tool, which is a irrigation suction device, which gives you the advantage of the sitting position. So what is the advantage of the sitting position? The advantage is very clearly that the surgeon has 2 hands for dissection. You can do a bimanual dissection because the assistant can irrigate continuously the field, and you have a clean field. You always anticipate the anatomy. There's no blood. There's no coagulation. Even in large vestibular schwannomas, I never use any coagulation because of this tool. So this needs to be body warm ringer solution. And when we are working close to the nerve or in smaller tumors, we use a papaverine solution, 1 in 100 dilution to prevent vasospasm. And you can use it as the surgeon as well. As you see in the left video, this is the surgical, when the surgeon is using this device, or the assistant, he has to angle it more steeper because he comes from the side. The tip of the irrigation device should always be in the field, that the assistant knows exactly that he should irrigate at the tip of where the physician, the surgeon is dissecting. Now, this part is very important as well, because nobody can work like this for 5, 6, 7 hours. So you have to put the microscope in the correct position, and you need, especially for the Pantera microscope, you need a semi-sitting adapter, which allows you to angle the tube even more. So that's obviously not going to work, because I would not be able to do this longer than 20 minutes, right? So this is more relaxed, but you see that the handle is in your way. You're always bumping with your right working arm against the handle. So you have to release the handle and tilt it either inward or outward, like however you like it. So I like it inward. So with this position, this is a very nice ergonomic position. We have a crossbar for the wrist, and that the wrist is nice and settled, and you work with your, the dexterity comes from angulating the instruments at the border of the craniotomy. And in this position, with looking downwards, although you look upwards in the microscope, you look very nice, relaxed downwards with your cervical spine. This position you can easily do 5 to 7 hours with no problems. But it's very important to have this good distance to the microscope. And I think if we think about the future, the exoscopes will help if they have a good depth of field and a good light inside the posterior fossa. The exoscopes will improve the ergonomics for the surgeon in their sitting position, because the tube of the exoscope is much smaller, and you don't have to wrap around that much like we do it with the bulky microscopes we have right now. Okay, now let's do it. And again, the jugular compression, before you start surgery, you have to make sure that the anesthesiologist is available and aware and has constant access to that area. So he needs to not to go under the drape and 30 seconds, 40 seconds until he finds the jugular veins. This needs to be within seconds. So we always make sure before skin incision that he can reach both jugular veins within a second, right? That if I see something, if they see bubbles in the TEE, they reach the jugular vein with no problems, right? And they have monitors, so they see the surgical field. I see the TEE, and we see also the anesthesia monitor, that we have all information available at hand. Now let's come to the surgical part. So this is the right side, retrosigmoid opening. I open in a safe area, away from the sinus, about 1 centimeter. This is why the craniotomy need to go all the way. You need to see the blue line of the transverse and sigmoid sinus, because you're losing about ½ centimeter for the opening, because you have to close it later on in the watertight fashion. So, but I start away from the transverse sinus in a way that I'm sure I don't cut into the sinus, right? And then when you see that the cerebellar folia got horizontal, then you know you're just above the cerebellum, and you know you're at the right time. So you do a lateral tacking suture, and then the next step, before you place any spartanus, you release CSF from the cisterna magna, right? You see, you release CSF in a sitting position, very easy, straightforward. Now the cerebellum is relaxed, and you put in a cottonoid paddy, just against gravity. And then you put the Apfelbaum retractor or Lila bar retractor, and this retraction is only against gravity. You don't really push the cerebellum, it's just against gravity. You see that here, this needs to be optimized, but you see the petrous ridge is going straight in the depths, and on the left side you have the spatula, and you just watch the tumor for the first time. And then, of course, you have to adjust a bit and move towards medial and towards lateral. Now, when it comes to drilling of the internal auditory canal, there are several things to consider. And if the patient, for example, has no hearing, I start with a cutting burr. If this is about hearing preservation, I always use diamond burrs with decreasing sizes. As you see here, we start with 4 millimeter going down to 2 millimeter. You have to stay above the endolymphatic sac, and you should not go more than 8 or 9 millimeters into the canal, because then you would reach the semicircular duct, which you then might lose hearing as well. And keep, of course, the dura over the canal during drilling. You have to drill open the canal 180 degrees to really open it half moon shape, because the reason why you open it, you want to mobilize the tumor and the nerves. So if you don't open it properly, you just squeeze the nerves when you go in with instruments. So even you can lose hearing just from pushing with your instrument in the canal, because there's not only pressure from the tumor, but now you apply additional pressure with your instrument. So you really have to open the internal auditory canal in a way that it is decompressed and that your manipulation does not increase the intracranial pressure, right? So now I opened the dural band over the internal auditory canal, and then you can start mobilizing the tumor from lateral to medial. I always do this at the beginning of the surgery. You identify the facial nerve. If you're not sure, you see the facial nerve here on the right video very nicely. You can use the monopolar stimulation for the nerve if you need to. And then I leave it that way, right? I don't pursue any further. I know I luxate it out. I remove the lateral part of the tumor. So now that's done, okay? Now I place a gel foam sponge soaked in papaverine. I put in the most lateral part in there, and I don't have to go back. This is the first step of the vestibular schwannoma surgery in our hands. And then we go to the medial part. Even if it's a very large acoustic schwannoma, we do this part first. Why? Because if you work in the CP angle and you debulk this large tumor, there's a lot of manipulation and traction and force at these nerves, which are so compressed at the entry into the internal auditory canal. Now we debulk it in this area, and then all the manipulation in the CP angle later on gives less stress on these nerves, who sometimes run from the internal auditory canal and here along the petrosus ridge, and then going to the brainstem. So they almost do a 90-degree king, right? And then if you move back and forwards with your manipulation during resection, you could injure or harm the nerve more. This is why we do the decompression at that part first, and then we move on to the systemic part. I want to go back to this landmark, and this was the nice study we did in Tübingen. You see where the dura starts to get these wrinkles. This is the Tübingen line, and this is the lowest and most inferior line of where we should drill. So if we drill below, you go into the endolymphatic sac, and there's a very high chance that you go into the jugular bulb if you drill below there. So the area where the dura gets the wrinkles, this is the Tübingen line, and above there you should start your drilling and the dural resection and the opening. So the opening of the internal auditory canal is more superior anterior rather than posterior inferior. Okay, so I have to look at the time that I don't lose time. Okay, we're all good. So now I want to show you the advantage of the sitting position, the bimanual dissection, grabbing the tumor, dissecting the capsule. You see this in both videos parallel, right? So you see constant irrigation to the tip of your instruments, and there's no need for any coagulation, and the water will be washed out by gravity, and you have a nice plane towards the brainstem. You should always know that the capsule of the vestibular schwannoma does not contain any vessels. So when you see vessels, it is not tumor. If you see vessels, it's capsule, right? So now you change your instruments. You take the tumor forceps into the left hand. This is towards the brainstem. You have to peel away from you, which is more difficult, I have to admit. If you have to peel away from you, then gravity does not help. This is superiorly the dissection towards the trigeminal nerve, which is much easier than inferiorly. Right, on the left upper video, you see very nice dissection. This is hearing preservation on the T3 vestibular schwannoma. You see, you don't touch the nerve, you just touch a few millimeters. This is hearing preservation with this nice technique. On the right side, again, you see in real time dissection at the brainstem level away from you, right? And always grabbing a little bit and then pulling and pushing away from the brainstem, right? This is very important. Don't touch the brainstem, touch the capsule, right? So now, if it's bleeding, no vestibular, no coagulation, right? Everything which is safe, you can easily remove with a CUSA in the safe zone, because grabbing and holding the tumor against gravity is exhausting. So you should have small tumor parts. And you see very nicely, nice arachnoid plane here, very nice orientation. If you find a nice nerve like this, it's unfortunately not the facial nerve. This is the abducens nerve. And then you go to the brainstem. There are adhesions, but it can be very nicely dissected because you have a nice clean plane, no coagulation necessary. You have a good assistant who's irrigating on the tip of your instrument, that you basically flush and blush the space you create. Body warm solution can be with papaverine, as I said before, and you see how nicely you bring away all this tumor from the brainstem. Okay, so that's the bimanual dissection. Now, remember, again, this is important. If it's bleeding, this is a post-radiation vestibular schwannoma, brainstem level. So this is bleeding, bleeding, bleeding. No coagulation. It's generous irrigation. And unless it's arterial bleeding, then you have to coagulate. But this is venous bleeding, and you see how hard it is. Even with the forceps, you can't dissect it. So you need to do it sharply. But don't use coagulation. Use constant irrigation. We call it the underwater technique, right? So underwater, you see a clear image, and you use the scissors a little bit away from the veins, because the veins eventually will stop bleeding, right, when the pressure is out. But there might be connection which you coagulate if you use the bipolar, right? And still you see it doesn't work. So don't give up, but don't coagulate, right? Use again the scissors. I just want to show you, because this is a very typical example. A lot of adhesions because of previous surgery and previous radiation. And this is at the brainstem level. So then you put a sponge there, and you can either wait or you proceed, whatever you like. And then at one point you found the best plane, and then you can proceed here with pulling and pushing, and see you overcome this very severe adhesion without coagulation. So that is the philosophy. But whatever it takes, avoid bipolar cautery. Okay. And again, I want to show you this again, right? So this is at the brainstem level. You see very soft brainstem. And again, a very nice nerve here, but unfortunately, it's not the facial nerve, it's the abducens nerve. Arterial, some arteries going into the capsule, into folds of the capsule here, like this. It will start bleeding eventually, but if this starts bleeding, and sometimes you don't want to start the fight, with an underwater technique. You just put a sponge there, you wait a few minutes, you go to another area, because you have many areas where you can work on, and then you come back like 10 minutes later to that specific area and continue your dissection. So it's very important that the electrophysiologist has a good view over the field, right? The electrophysiologists need to see anesthesia, need to see intraop images, which is part of his screen, and is observing all the monitoring in real time. So when we see a facial spontaneous activity, and we make this audible for the team in the room, and if there are A trains, and the A trains stay longer than 20 seconds, we stop surgery, we do irrigate with body warm Springer solution, we use papaverine as well. Just take our time, and most often after a couple of seconds and minutes, it's over. Because we should know, if we have A trains longer than 1 minute, it's a bad predictor for decreased facial nerve function post-surgery. It doesn't predict the recovery, but it does very good predict the initial facial weakness after surgery. So the electrophysiologist is also looking at the blood pressure, that the blood pressure is always around like 80-90 MEP, that because drop in blood pressure can mean drop in hearing or drop of hearing deterioration or drop of acoustic evoked potential. So this is very important for the electrophysiologist to see as well. Vasospasm, we talked about it, you see here, very severe, very focal vasospasm, right? And this needs to be taken care of with papaverine sponges or papaverine irrigation. We just place it there and wait a few seconds. You can do surgery and tumor resection in another area, leave it there, and you will see after a few seconds or minutes, right? This is lower brainstem, by the way. You see it's completely resolved back to normal. But you have to pay attention to these little details before you have a neurological deficit. And if you have SSEPs lost, then it's too late. You see, this is at the end of surgery, complete resection. You have to seal the internal auditory canal, whether you take fat or muscles. This is an academic question. I don't see there any difference. I glue it to make sure it's sealed, specifically when there is pneumatization visible on CT scan. You have to also tell your radiologist that this patient has a muscle on there. I want to go back and show this again. So you see this very nice arachnoid plane with a facial nerve, very nicely preserved. And then you see the facial nerve going anteriorly, you place the muscle, and you have to tell your neuroradiologist, or you even have to tell the patient. They will come back with a report from neuroradiology, oh, there's tumor remnants, because the radiologists see the contrast enhancement at the level of the internal auditory canal. He doesn't know how you do. You see the internal auditory canal, this is not tumor, this is the muscle patch. So that needs to be documented very well, that the patient is assured that this is the tumor muscle, this is the muscle and not tumor remnant in the canal. Now, at the end of surgery, we do, of course, the jugular compression to check again if there's any occult bleeding. So left side, you see under compression, there's no bleeding and there's big bulging. On the right side, you see under jugular compression, you see subtle bleeding, which you didn't see. You didn't see without jugular compression. So you can look at the source, don't coagulate the Dandy's vein, the superior petrosal vein, don't coagulate it by all means, try to preserve it. But you need to make sure that this is no bleeding under increased intracranial pressure, because the patient will wake up with gagging. They are all very nauseated after surgery when you work on the vestibular nerve, and then they have gagging, they have increased intracranial pressure, and then they have post-operatively, they have blood in the CP angle system, which again can create problems, right, with vasospasm and hearing deterioration. So the jugular compression at the end of surgery is very important to look in very much detail around the brainstem and around the tentorium if there's any subtle bleeding, which you wouldn't see. Very important. Okay. Now, how demanding is the surgery in the sitting position? We did an analysis of the duration of surgery and the exhaustion of the surgeons. We looked at 150 consecutive cases of T4 tumors. Craniotomy enclosure is done by residents, and you see on an average, this is 230 minutes. So it's about 4 hours for a T4 acoustic schwannoma in the sitting position. So it's much faster, much more straightforward. It requires less intraoperative steps. We talked about 200 steps, but if you count the steps of the instruments, right, you need less because you never use the bipo. You just have the tumor forceps and dissection forceps. You might change from right to left. The assistant has the irrigation device. You don't do anything else, right? In between, you use the CUSA, but there's no back and forth with bipolar, no pedis. Pedis are actually not very good for the nerves. So with significant degrees of variation in use of instruments, you cut down the resection time significantly. So I believe 4 hours for a T4 schwannoma, including craniotomy enclosure, is pretty straightforward in an experienced team. So that is actually the end of my lecture. I hope I was in time. It's about 35 minutes. That's perfectly. My mentor always said, an ultimate plateau of learning is never achieved, never reached. And this is someone who did 3,000-4,000 acoustic Schwannoma in his lifetime. None of us will reach that number because we have many, many good surgeons now all over the world. And we have radiosurgery, which is a very good competitor to us. So I, for myself, I learn every single day. I did a case today where I learned a lot of things. You know, you always have a situation which you never had before. So I really appreciate feedback. And I also want to make sure that these 200 steps are very important, right? With any of these steps being missed, I don't believe that you can do it as safe and as successful as we do it at the Cleveland Clinic. Thank you very much for your attention.
Thank you, Professor Rosa. That's a very excellent lecture. So is there any comments or questions from Professor Liu?
Thank you, Professor Connor. Thank you, Professor Rosa, for very informative lecture and comprehensive. I wish to ask Professor regarding two different techniques, intracapsular and extracapsular approach, especially when we cannot really identify the facial nerve pre-operatively from the imaging, and also intraoperatively difficult to find the facial nerve. Which one is the safest to do? And whether a lot of time that people say that you need to study the pre-op imaging, where in reality that you can actually find the facial nerve. I want to know how true is it? I mean, how current advance in imaging, how true that we can always identify facial nerve before surgery?
Yeah.
My last question, Professor.
Yes.
One last question, Professor. For facial nerve stimulation, usually when we get the signal, it doesn't indicate the intact of the nerve because it always shows the distal end of the nerve that intact. So we wouldn't be able to know the proximal part. So how do you ensure the proximal part is also intact? Thank you, Professor.
Yes. That's a very important question. I really appreciate it. Your questions demonstrate that you have a very good understanding of the topic. So first of all, before I enter the capsule of the tumor, I always do mapping and do some simulation, right? We know that in non-NF2 patients, the tumor always arises from the superior vestibular nerve. And we know that in almost all cases, the facial nerve is running anterior, inferior around the tumor capsule, at least from the sitting position, right? And that the cochlear nerve is running inferiorly over the tumor capsule. We know that, right? In NF2 patients, it can be the other way around because the tumor can come from any nerve. And in that case, it is extremely important to do mapping before you enter the capsule, right? So this is why I do stimulation of the surface in any case, just to make sure, right? Because you never know. If it's the 1% where it's the inferior vestibular nerve, then the facial nerve is superior, right? And then you might have a problem. So I always do the stimulation first. I don't trust the MRI imaging, the DTI and the facial nerve. I don't. That's a little bit like trigeminal neuralgia when they tell you, oh, we have a neurovascular conflict on the right side, right? But the pain is on the left side. It's a little bit similar to that. It's a nice academic tool, and I think moving forward in the future it might be possible. But right now, I wouldn't give credit to that. That I would rely on that, right? It might give you an idea, but I wouldn't rely on that. And the last question is how we make sure there's integrity. Now, when you do MEPs of the facial nerve, right? With the MEPs, you have a good answer about the integrity of the pathways, right? You have to make sure that you don't stimulate too high, because then you bypass the central pathways and you have a peripheral stimulation. But if the MEP stimulation is close to the baseline, then you had at the beginning of the resection, then you know it's a peripheral, it's a central stimulation. But you're completely right. At the end of the surgery, right, when let's say there was an angry nerve and the MEPs are going a little bit down, or the EMG is not as good, you have to stimulate at the proximal end. You have to move the microscope to the medial angle. You have to identify the nerve exit, and you stimulate medial at the brainstem level, because peripheral you will always have a nice exam, right? You can cut the nerve, you stimulate distally and you have a good exam and you say, oh, nerve is okay. No, you always have to stimulate proximal at the brainstem level.
Thank you very much, Professor.
Thank you very much. That was very interesting. Yes, I would like to ask one question to Professor is that how many times in your resection that you have come across an anatomically intact but electrically unresponsive facial nerve? If at all you come, what do you do? What is your next step?
Yes, and again, that's a very good question. We do see this, right? We do see this, that we have a straightforward resection and we have actually pretty stable electrophysiology. Maybe the nerve was a little bit angry. Maybe there were some short A trains, and then afterwards it's a nerve block, right? And I think this is from traction. So because we created an axonotomy, right? So because if you pull on the nerve, that's actually, the nerve doesn't like it. You can move the nerve up and down. For example, if we do a petroclival meningioma and we have to work anteriorly to the facial nerve, right? You can move the nerve up and down. That doesn't matter. But if you stretch the nerve, the nerve doesn't like it, because then you stretch the fibers and you create axonotmesis. And so we see this rarely, but we see it, especially in these large tumors. There's so much manipulation around the nerve, dissecting the capsule, and again, you need to discuss with the patient before, right? If you find a lot of adhesions, you can ask the patient if he is agreeable that you remain a small thin layer of tumor capsule on the nerve to preserve the nerve, rather than being too radical, right? And sometimes when they have a complete palsy afterwards, but we had a good stimulation intra-op, I'm very sure that these patients will recover. It might take 6 months. It might not go back to Hausen-Breckman grade 1, but we have several patients who had a complete palsy afterwards. They had good stimulation at the end, at the brainstem level, and then they come back to at least grade 3 after 4 to 6 months.
Thank you very much. One another point that I would like to make, since you showed micro bleeding from the tumor capsule vessels, one thing that I observed when during my fellowship in Japan is that when at Professor Kato's place, they do a lot of cerebrovascular surgery. So the small tiny veins and small arterioles may give away. So in order to seal it, they usually have this thrombin solution, with their thrombin solution, fibrin glue contains the sealer protein as well as the thrombin solution. So what they do is they chop small 2 to 3 millimeters of gel form, right? And they soak it in the thrombin solution. And when they have this types of bleeding, they simply put that thrombin soak solution and inject the fibrin sealer protein solution over it. So it generally stops there. So that is one point. Professor,
very nice idea. Very nice idea.
Professor Kono
I will use it. Yes.
Professor Kono can improve on that if there are other techniques that you would like.
Excellent.
So, is there any comments? No. Professor Roser, you didn't mention about the preservation rate of the facial nerve functionally. So how much?
Yes. So in our series, which is continued from Germany, it's about the preservation rates we see, right? That in the very large T4 acoustic, and that's basically what we see here in the UAE, right? I don't do surgery on small acoustics anymore, right? Those patients want to go, we go for observation, or we go for a gamma knife. Only if there's disabling vertigo, then we do surgery on small acoustics. Otherwise, we're very conservative. So we do the very large ones, actually. And unfortunately, specifically in the UAE, we have many failed gamma knife patients, right? So I have a facial nerve preservation, functional preservation rate of about 85% in these large acoustics. And anatomically losing, we do the nerve rarely. I would say that's less than 5%, right? But I see the more post-gamma knife schwannomas I do, the less I'm afraid of. Post-gamma knife is not so difficult. But what is most difficult is partial resection. If they come back, that's a disaster, because you have so much scar tissue in that area, and you don't know how the surgeon approached it. Whether have they been intracapsular or extracapsular, and that's a very poor preservation rate in those patients.
Okay, and so you don't take tumor totally always. So you can so control the removal rate, resection rate, 95 or 97% resection, or
yes. So I open the internal auditory canal always. I always open it to remove it from lateral to medial. And in very rare circumstances where there's severe adhesion to the facial nerve, and this is a young lady, and I discussed with her before surgery, and she says, by no means I want to have a facial nerve palsy. In those patients, then I do a near total resection, which is really like a small layer of tumor on the facial nerve. And sometimes we don't see this on MRI, but I know there is some tumor layer on the facial nerve. But other than that, I always go extracapsular. I try to remove it completely. And the recurrence rate is far below 2% over the 10-year observation rate we have, right? So now I'm not favoring the partial removal and then gamma knife concept. That's not healthy in the future,
okay.
Specifically in young patients.
In surgery for patients with a high located jugular valve, so you do the semi-sitting position, or
very good point. So high jugular bulb, I don't do sitting position. High jugular bulb, I do supine position, head rotated, like we do an MVD procedure. And then in those cases, if it's a small tumor, we use the endoscope to really go in and look into the internal auditory canal, and then go beyond this jugular bulb. So the endoscopy in the high jugular bulb is helpful.
In hypervascular vestibular schwannoma patient, so you don't do coagulation.
Nothing. Hypervascular is the same concept. You need a lot of irrigation, right? And the floor in the OR is swimming at the end, but no, we really try to avoid unless you have an arterial injury for sure, or small artery, then you use cautery. But other than that, you stay in the capsule. Yes, it will bleed, but if the tumor is out, it stops bleeding.
Okay, that's a merit of semi-sitting position.
Yes, it is.
Yes. Okay, so Raja.
Thank you very much. That was indeed a very wonderful lecture, and we learned a lot, and a wonderful discussion that followed.
Thank you so much.
I would like to inform our viewers that this has been broadcasted on WeChat, YouTube, and Zoom, and as of now, we have around 495 people who have already joined us live, combined all three platforms. So thank you very much.
Excellent. Thank you so much.
Wonderful lecture. Thank you very much. So we'll move on to this. Yes, Professor Reisner, you were talking something.
Yeah, I'd just like to, sorry for jumping in, just like to thank Professor Rosa for an outstanding speech and outstanding lecture. I mean, the nuances and your attention to detail are quite amazing. I wished I'd watched this talk last night. I would have thrown in some large, big pediatric brain tumors just to complement your talk, but it's going to be a little bit hard to you in a different way, but just outstanding work.
Thank you so much. Thank you.
Thank you very much. It was indeed an outstanding work. So we'll move on to the second session, and I would like to hand over this podium to our second chair, Professor Tariq Khan, who will be saying a short introduction, and invite Professor Reisner for his lecture. Professor Tariq Khan, all yours.
Yeah, thank you, Raja. Indeed, a very good lecture given by Professor Roser. A very good talk. So I would like to invite my friend, Professor Andrew Reisner, to give his talk on Translational Neurotrauma Program at Children's Healthcare of Atlanta. It's a very important topic. I think important how to use the bench research to improve patient care. So Andrew, please.
Thank you very much, Professor Khan, and give me 1 second while I get my slides up. And while they're coming up, I'll again thank Dr. Rosa and just tell the audience that was just an outstanding how to talk on the nuances of acoustic neuroma surgery. Mine is also a how to talk, but something a little bit different, not so granular, not so patient related, certainly not in the operating room all the time, but perhaps a little bit from a higher altitude. And it's a how to marry your clinical interests with research. So thank you, Professor Khan, for that introduction. I want to be respectful of everybody's time, so I'm going to set my timer as well. Here we go. So the title of my talk is Translational Neurotrauma Program at Children's Healthcare of Atlanta, from bench to bedside. Translational, what does that mean? Well, that means basically marrying your clinical interests, more importantly, perhaps your clinical problems that you see, coordinating with our research and bench colleagues, and answer questions that come up at the patient's bedside. I'd like to thank Professor Raja Krishnankuti for this very kind opportunity to be here, as well as his colleagues from the Asian Congress of Neurological Surgery, especially Professor Yoko Kato, who's been very, very kind to me. So let me start off by bringing greetings from Atlanta, Georgia. Anybody has travels come this way, I know you'll reach out to me. We'd love to show you around the city and also the Children's Hospital. The Children's Hospital is a very large pediatric tertiary care system. Just to give you some statistics of what I mean, there were 27,000 inpatient admissions last year, 1,400 pediatric neurosurgical procedures, and we have two large neurotrauma programs, the TBI program, which treats about 400 severe TBI programs a year, and a concussion program that deals with at least 3,000 per year. Before I go any further, I have to thank my wonderful co-workers, Drs. Blackwell and Saeed, as well as the amazing team that we have, especially and led by Drs. Verma, Maria Cordero, Arthur Benuo, and Arpit as well. Let me say real quickly, I have no, a little bit of housekeeping. Here are my disclosures and fundings. I have no other financial interest to disclose. All pictures are with the patient's permission. So what am I going to talk about? Well, this is a talk that frankly is directed more to the younger, early career residents, registrars, young attendings, rather than the older ones with gray hair like myself. I'd like to share my career with you, and let me quickly say it's not the only path and certainly not the best, but it's a path that I took and maybe will resonate with one of you. I'd also like to give an overview of the Pediatric Neurotrauma program at Children's of Atlanta, and there are really three parts: the severe TBI program, the concussion program, and the Pediatric Neurotrauma Lab. Let me quickly state, none of the three of them existed 15 years ago. These were all built from scratch and out of need. And just like Dr. Rosa gave a talk on how to with acoustic neuromas, maybe I can give some pointers as well as how to develop these programs and how they benefit the community and our patients, of course. Our focus of our lab is on biomarkers, and also chat to you about that and future directions we wish to take. Again, huge thanks to everybody here in Atlanta who have supported this effort greatly, as well as the fantastic team that we have. I, like all of you, didn't arrive here. We have wonderful, I've had wonderful mentors along the way. Quick thanks to my late professor of anatomy, Professor Tobias, the head of neurosurgery where I did my residency, Dr. George Tyndall, and his successor, Dan Barrow, and Mike Edwards, who's my fellowship director. Again, something to the younger neurosurgeons, one of the many wonderful things about being a neurosurgeon is that you meet inspiring people along the way, not just when you're a resident and a young attending. And that happened to me this last year. I have got involved with the World Federation of Neurosurgeons, and perhaps a highlight for me has been get to meet people like Franco Servade, the past president, Tariq Khan, my immediate predecessor, Nasser El Gandor, and as I mentioned, Professor Yoko Kato, who has helped me a lot develop the team and in our committee. So why am I interested in neurotrauma? Well, it's quite simple. It's the #1 cause of death and acquired disability in kids between the ages of 1 and 18. Here's some statistics from the United States, they're a little bit old, but I'm sure they're no different this year. 50, maybe 60,000 deaths occur because of traumatic brain injury every year. For kids in particular, it's a serious problem. It resonates with both the family and society at large, especially one considers that these children were normal minutes prior to the injury. On a worldwide scale, Professor Khan and Servade and Andres Rubiano and many others have taught us how significant this is, especially in the lower and middle income countries. This is a map of neurosurgery coverage, and this is a map of trauma. And you can see the disparity where trauma is so prevalent. We have a dearth of neurosurgical care, and that needs to be corrected. I've already addressed our children's hospital. Perhaps I could just quickly draw your attention to this picture. I'm not sure if you can see my cursor, but it's a brand new hospital that's being built and will be opened up in 2024. 19 stories, 600-700 inpatient beds to serve the entire Southeast region. So what am I talking about? Well, neurotrauma, and that includes the entire spectrum on the Glasgow Coma score, from severe Glasgow Coma score less than 8 to mild less than 13 and moderate in between. I don't think I need to belabor what the Glasgow Coma score is to this audience at all. However, I do want to say to the junior residents, again, this is a saying I absolutely love for somebody who's been doing this for at least 4 decades, who's watched mentors and watched people who've been very inspiring to me and people who have perhaps not been as inspiring. Those that have been the most inspiring are people that, whatever the age, try something new, open to new ideas, solve the problems that they come to face with. And I think Robin Sharma said it better than I could. Don't live the same year 75 times and call it a life. And as I said, hopefully I can share a little bit of the lessons I learned on my journey with you. I'd like to tell you that my journey was like this gentleman over here, Einstein, perfectly laid out, Nobel theories at 21 years of age, but unfortunately it's not. It was a little bit more meandering. For those of you that's seen Forrest Gump, it was a little bit of bumbling along from one serendipitous event to another. And I'll start off with the most recent. The most recent was my interaction with the World Federation of Neurosurgeons. And I'd like to speak to this wonderful organization for a minute or two. What is the WFNS? Well, it represents all of us. It is, as far as I know, the only global neurosurgical body. It was founded middle of last century. There are a number of standing committees, professional societies, ad hoc committees, including trauma, spine, pediatrics, etc., those separate from the foundation that promotes worldwide development. In a way, the history of the WFNS mirrors the history of modern neurosurgery, certainly in the United States and Europe, and I'm sure Asia as well, where we got, and I think the word is correct, emancipation. Neurosurgeons needed to be emancipated and freed from our general surgery colleagues, develop our own divisions and departments, and neurology colleagues. I would just point out in researching this for this talk, it was interesting to find out that the neurologists in Germany went through the same thing, emancipating themselves from the very strong and prominent psychiatry departments that were there. Our history is long and storied, and this picture says it all. Here's Sir Charles Sherrington, the famous British neurologist, Harvey Cushing, and William Welch. For those of you that don't know William Welch, I would strongly recommend that you read this book, The Great Influenza, where this was written pre-COVID and speaks about the great influenza and the influence that he had on modern medicine. Why are we here? Louis Pasteur said it best, and I think that this epitomized the World Federation of Neurosurgeons better than anything else. Science knows no country because knowledge belongs to humanity and is the torch that illuminates the world. So it's both the science and the humanity. I've followed on from giants, and I've already spoken about Dr. Khan and Professor Hutchinson from Cambridge. They had a particularly tough time during the COVID time. That was very unusual. To say it's unusual is an understatement. COVID-19 has taken a toll on all of us, and I know all of you who are listening as well. We've all lost family, friends, and colleagues and felt the stress of social upheavals. The pandemic has taught us much, professionally and personally. Perhaps most important, we don't take fellowship, friendship, and personal exchange for granted, as perhaps we used to. It's also reinforced what we should have known previously. Us neurosurgeons are not divorced from societal issues at large, such as mental health issues, and our craft and our field needs to extend beyond the four walls of the operating room. And just in case I need a reminder, here's some cases that I have dealt with in Atlanta. This is a 12-month-old baby, 1 year old, who sustained a gunshot wound to the head secondary to some family violence. The patient arrived in the emergency room, CPR was initiated. I won't go through the details except to say it was not good. Here's a CT scan, significant pneumocephalus. I'm not showing the gunshot wound tract. The gunshot wound entered the forehead, ended up in the upper cervical spine. Here's fragments of bone and bullet, and of course, this child did not survive. This is a second case, a child transferred to our facility. A lot of bruising, bleeding, head injuries, and we suspect and know it's due to abusive head injury with the classical signs of hypoxic ischemic injury, retroclival or extraaxial bleeds, as well as associated problems such as healing fractures of different ages, long bone fractures, and this certainly is a case of abuse. The third case, perhaps the luckiest kid in Atlanta, a teenager. These kids were just fooling around with guns. One nicked him in the thorax, and here he is, got a pneumothorax. And again, the luckiest kid, the bullet lodged in the pedicle, and he walked out of hospital a few days later, fully intact. Perhaps the unluckiest kid, again, less than 2 years old, family violence, a gunshot wound. Here's the entrance wound. Here's the exit wound. As we were rushing this pretty young girl to surgery, again, we noticed a little nick in her forearm, got a quick x-ray, which wasn't delaying things, and there was a bullet, and I can only assume she had her hand above the exit wound to no avail. Here's a picture of her. Here's a picture of the aftermath of my very unsuccessful attempt to save this child. And here's yet another one. A 2-year-old sustained a gunshot wound to the head. So again, going back to COVID, these red is the COVID years. You can see how the number of COVID cases has increased exponentially. And unfortunately, this trend continues, not only for gunshot wounds, but also for abusive head injury cases. That is the old shaken baby in kids under 2 years of age. Again, this trend is increasing, probably because of COVID, and certainly COVID is not helping. So back to the WFNS, my theme for these 2 years is to recover and restore. And a quick shout out and reminder to you that we, the whole committee, prior committees, are here to be a conduit for you, whatever a personal, local, regional, global initiative you want to embark on that can better help the victims of neurotrauma. It's as simple as that. And again, recover and restore. That is my theme for these 2 years. Ably assisted by, if I can give a quick shout out to 2 wonderful colleagues, Andres Rubiano in Colombia and Laura Lippa in Italy, both of whom are well published, have a keen interest in neurotrauma and have been wonderful supporters, as well as 30 or so other members of the neurotrauma committee. As you look carefully at the screen, you'll see that there's not only geographic, but also gender diversity that brings wonderful expertise to our committee. So earlier this year, we had our first in-live meeting. There's a smiling picture of Professor Khan, Andres Rubiano, and myself. I'm sure Professor Khan will agree it was wonderful to meet in Bogota and initiate our programs, which include, and I'm not going to belabor them, some research, education, reaching out to those in need, a consensus statement, and ICRAN. ICRAN is a meeting that we have, which is the International Conference for Recent Advances in Neurotrauma. Here's a few snapshots of the neurotrauma programs that we've had. And this is a consensus statement that we're doing on spine injuries. So much for the WFNS. And I'd like to circle back and tell you about our experience here at Children's Hospital. Again, 15 years ago, there was nothing here. But we had all the building blocks. We needed to just put it together. And we need to organize it. One day I was on Google and I Googled heaven, and this was the first picture that came up. So our goal is to go from a mess to heaven, and that's what we accomplished by putting together a team of interested parties, ICU doctors, nurses, administrators. This is our mission statement, and here are the cases that we deal with. This is Brianna, a 4-year-old female at a football game. This is what's left of the Corvette that slammed into Brianna and her mom. She was taken to a hospital, underwent a removal of a subdural. It wasn't that large. ICP was normal, but we knew that she was going to have the inevitable problems of swelling afterwards. She did. We managed it with our guidelines, which I'll address in a second. This is Brianna post-op, and she lived and made a nice recovery. Unlike the second child, also 4-year-old Avery, same story, barely made it off the table. We did a decompressive crania on her. She had massive DIC, and unfortunately, she died within 24 hours. So we put together a group of us physicians, not just neurosurgeons, but all allied physicians who deal with trauma, and put together the severe traumatic brain injury program. The goal was to have more outcomes like the first and less like the second case. We have a highfalutin mission statement, but I think you can see what we're doing. This did not happen in isolation. This was a push in medicine in general, starting in the early 2000s on evidence-based guideline. You don't need to read this entire slide, but I do want you to remember this date, March 2011. That's when we initiated our guideline, and I'll address that in a second. We have evidence-based guidelines. My job as the leader of this group was to guard against it vigorously, but not to be so, realize that this is not in stone and introduce new findings as they come. For example, we introduced nutrition. We started having a pivot towards normal saline rather than mannitol. We also realized that we couldn't, and we weren't going to advance the field by doing yet another 300 craniotomies in the middle of the night. We needed to do research, and we started off with clinical research. We then advanced to our lab research, which I'll chat about. And this is one of the clinical programs that I'd like to tell you about. And again, a lesson here for perhaps the junior people, because it really made a huge difference to the way we manage severe traumatic brain injury in children. So this was our hypothesis. Implementation of a guideline would improve outcomes. Again, I asked you to remember that date, March of 2011. We instituted the guideline. They became enforced by our medical executive committee. What does that mean? It means that there was no wiggle room for any doctors to do what they were trained with. So we don't want to hear what the Duke way or San Francisco way or whatever way is. Everybody has to do it according to the guidelines. If not, they have to explain. It's hard and fast. If they wanted to change the guideline, we certainly were open. And we compared the two groups, before and after the guideline. Our mortality rate improved by 40, one more time, 40%. In other words, 1 in 3 kids that came in before died, 1 in 5, more or less, died afterwards. As you know, severe traumatic brain injuries, complex, many, many factors for this. Certainly, one of the factors is that because everybody, including the nurses, now are on the same page, the time of elevated ICP was reduced, and that improved the outcome. We published this in the Journal of Neurosurgery Pediatrics, and I mention this because one of the criticisms that we got from the reviewer was that, gosh, maybe this is the Hawthorne effect. So what is the Hawthorne effect? The Hawthorne effect, which I did not know at the time, is basically once you focused on something and you shine a spotlight on it, it improves just because you're paying attention to it automatically. We gave an answer, no, we didn't think it was. And I think our answer was correct because, as you can see, this improvement has been sustained, and very gratifying to us that this works. When it works well. Here's one case, a 4-month-old male who fell, lost consciousness, came in with a epidural hematoma. Here are a couple of quick pictures, which I'll show you. Video. I'm going to fast forward it. Opening the scalp, getting rid of the blood, our craniotomy. And then you fast forward, there's the epidural hematoma. Perhaps more important than the surgical nuances is as the sign which says we've initiated the TBI guideline protocol. So everybody is on the same page. And here's the child just over a week later, normal and doing well. Unfortunately, not everybody does well. This is a kid who had a subdural hematoma. Here I am opening the dura. As you can see, not much brain swelling. And unfortunately, despite our efforts, both surgically and medically, here's his ICP 3-4 days later, and he passed away. So much for our severe head injury program. And I'm going to compartmentalize this talk a little bit. Let's pivot now to our concussion program. Because we started the severe head injury program, and quite frankly, it was successful, we were asked to meet the community needs for this massive tidal wave that we got of concussion patients. There was this tidal wave of concussion patients because of celebrated cases, murder suicides of star football players, wrestlers, boxers that all made the papers. Moms were getting worried about the kids playing football and concussion, a couple of terrible cases on the football fields, and we could not manage this need. I was asked to do it, and I agreed because not only is there a community need, but of course, as a neurosurgeon, I have interest in this, the second impact syndrome, which, as you all know, is when a child gets a second impact after the first and has not recovered. There's massive brain swelling. This was an example of a child with GCS of 15. Second impact a month or so later, before the child had recovered. It's terrible swelling. 2 months later, the MRI looks like a 80, 90-year-old male with tremendous atrophy. This is an intraoperative picture of another case that we had. Doesn't show up well on this 2-dimensional picture, but here's the brain. You can see a nice space between the dura and the brain, and here's the brain swollen with the EVD placed in. Just tremendous swelling on a child who got a second impact before he recovered from his first. So we launched the concussion program, very similar to the concussion program. Here's the governor of the state signing the concussion rules, which mandates that kids who got a concussion have to be taken off the field. We are a state resource. We developed an online algorithm on how to evaluate these children, a toolkit if you like, and you can find that if you Google it, the Children's Health Atlanta Toolkit. It's in English and Spanish. And we use the evidence-based guidelines, the gradual return to play, and videos online, etc. Again, just like the severe head injury program, we knew that to advance our program in the field, we needed to do research. So we embarked on some, again, initially clinical researchers. Perhaps the most important clinical research that we did is 2 papers. One, how we initiated this program. We could not manage this large volume on our own. And taking a leaf out of the book of people like Laura Lipper, where she spoke, and Gail Rousseau, who spoke eloquently about things such as task sharing, not task shifting. We didn't shift the problem onto the pediatrician. We shared it with our colleagues. We shared how to manage concussion with our colleagues. This was published, as was the results. The results are just what we want: decreased number of CT scans and ER referrals. These are the number. To help them, we established a nurse concussion line to answer questions from the parents and the pediatricians. We engaged the sporting communities in Atlanta. We're now involved in research in a major way with the CDC, looking at different functional MRIs after concussion, interface with a variety of academic institutions in Atlanta. Again, our website has a number of hits worldwide, and I'm pleased to say that we are about to start our first international neurotrauma fellowship. One of Dr. Rubiano's colleagues, Ms. Castillo, will be coming to spend 3 weeks from us, learning about our concussion program, how we established it, and taking it back to Colombia. And hopefully Dr. Khan will be doing the same the following year with one of his colleagues from Pakistan. So that's a severe head injury. That's a concussion program. Perhaps for me, the most exciting is the dovetail and the marrying between the two, where we started a pediatric neuroscience translational lab. Again, the goal of the lab is to establish a basic science lab established on pediatric TBI that can answer the clinical questions and improve outcomes. And I'd like to give huge thanks to Dr. Iqbal Saeed and Laura Blackwell as my co-workers. Dr. Saeed has been at this for decades, where he does rats experiments and animal models, and has helped us tremendously. Our focus is on biomarkers. So what are biomarkers? Well, again, I don't think I need to explain it to this audience, just to say that a great example is troponin. Somebody comes in with chest pain. Are they having a heart attack or not? Troponin is high, yes, low, no. We don't have that for head injuries. So a good question I'm asked is, well, why do you need it? I mean, let's face it. A kid's thrown out of a car at 100 miles an hour, lands on its head and comes in the emergency room unconscious. Nobody's going to say, gosh, maybe that kid's in diabetic coma. We all know it's a head injury, but what do we need it for? Well, we need it because we need to streamline approach. Do you do a decompressive craniectomy or not? Do you withdraw care or not? How do we guide medical management? And we need a marker to do that. And frankly, we are on the road to developing one. And I'll discuss that in a second. I think traumatic brain injury now is much like breast cancer, for example, in the past, where all women were treated the same. Now we have stratified treatment, specific. And we are getting to that point where we're going to have stratified treatment. Again, I put this little bit of context of history in. Head injuries are not new. Hippocrates described it. Great advances about importance of brain swelling in the 50s to 80s in our evidence-based guidelines. And here we are in the golden age, precision medicine, where we're guiding treatment by biomarkers and protein and genetic biomarkers. We presented our results in a recent meeting in Berlin, and I'd like to share some of them with you. Again, management of TBI is largely on CT scan and the Glasgow Coma Score. We need to streamline this. Pediatrics are neglected to a degree, certainly not as much as kids, as adults. Pediatrics are a little bit more difficult to study because the value of the biomarker changes with age. The amount of blood that we can get are limited. And of course, it's a vulnerable population. Here's me measuring the head circumference of a child, and you just measure the head circumference, we know how it expands. And that parallels the tremendous biochemical changes that occur in the developing brain. That said, we look at the same biomarkers. We look at neuron-based, glial-based, myelin-based, axon-based, those from the blood-brain barrier, and one that we're particularly interested in is inflammatory biomarkers. We came across this because one of our colleagues identified an inflammatory biomarker, osteopontin, in a hypoxic ischemic model. Osteopontin's a very attractive biomarker because it's normal in normal healthy brains. It's got a short half-life. So we embarked on a translational study, and this is a good example where we did it in the lab, gave mice mild, moderate, severe head injuries. We found that this particular marker was expressed not only in the brain, but the blood. And so we embarked on a clinical study where we looked at about 60 odd kids and measured the biomarker on admission, 24, 48, 72 hours. We compared it to a variety of clinical parameters, and we found that osteopontin, more so than the most commonly studied one, correlated with death, predicted positive and negative CT scans, and we published this soon after these findings, and we established, managed to secure funding for an NIH grant. And again, that's my lesson. Start small, clinical, a small grant, pilot studies, and move on to bigger grants and funding. We have just completed the NIH grant. I have the sign up here. Please don't take pictures, only because this study is, and I realize it's going to be on YouTube, and that's fine, but I want to remind everybody that these studies need to be validated within our lab, validated, they seem to be holding up nicely, and of course, go through the peer review process that they're going through at the moment. But just like the initial studies, we found osteopontin, this inflammatory biomarker, extremely helpful. Here's one or two cases. I think you can perhaps see the massive skull fractures and intracranial bleeds on a child that died. And there goes the osteopontin, the green line, zooming up. There's a child, a 4-year-old, that was ejected, and you get this biphasic curve. And we think that by differentiating the differences in osteopontin trajectories, one can tell whether it's mild, how this child is going to do, how aggressive we need to be on these kids. Do you need to do a decompressive craniectomy immediately, or do you wait till the ICP gets high? Just one basic question that needs to be answered. A busy slide, where we're heading. Really, I just want to focus on this little platform here that our colleagues are looking at. Basically, just like you measure a glucose at the bedside, I have no doubt that all of you, especially younger people, will be using one of those devices at the bedside, in the field, in the military, to measure the severity of head injury, just like we do to measure glucose for a diabetic. I'm going to end off with two quick, fun things that happened. If I can share one other thought with you, this journey into research is always a joyous journey. You never quite know what you're going to get. Here's one example. When we did our biomarker studies, we noted there's a number of outliers, kids at very, very high levels. What was going on? Well, we had them rechecked, and as it turned out, those very high inflammatory biomarker levels were in kids such as this one, who unfortunately was abused, came in with massive skull fractures, intracranial bleeds, even higher than kids that have motor vehicle accidents. And clearly, this is another example, clearly there is a different pattern of osteopontin expression in abusive head trauma than head trauma from other causes such as motor vehicle accidents. Blood is great. What about saliva? Our colleagues in England and other places, Tony Belly in particular, have looked at saliva in rugby players. The advantages would be tremendous. You don't have to take blood. Can you diagnose concussion or head injury in saliva? The physiology of saliva is quite interesting. The important thing for this talk is that both proteins and genetic markers can be found in the saliva. We've looked at mRNA biomarkers, and we've just done some preliminary studies that in the evidence of time, I'm going to go through fast. We've looked at football players, and these are the results. A very small cohort, exciting, a glimpse that there may be something there, but not enough for me to say to you, gosh, this is now going to be standard of care. What I am saying is that we have embarked on a much larger study now, where we've got now 300 kids as opposed to the 20 previously, where we are looking at their saliva biomarker profile and seeing if they can identify those that had concussion or not. One of the last things we're doing is looking at the different ways of collection, particularly to see if swabs are as good as having kids with concussion spit into a cup. If they are, it really opens up us looking at the younger kids and the comatose kids. So that's the journey of translational research at Children's. Let me conclude with my journey. This is a picture of my mother, who's a nurse. In the prior generation, I remember her being so happy when polio vaccine came out, because it was not widely accepted and people were affected by it. There was no efficient drug control like the FDA and other regulatory bodies. And so many kids took thalidomide and developed these limb deformities. She spent some time in the operating room, and exploratory craniotomies were common with a high mortality. Can you imagine surgery today with no CT scans or MRIs, scarce antibiotics? And I look to you, those younger people in our audience, and ask you to take the challenge. I would like one of you to give a similar slide a couple of decades hence. We're going to say what we're doing sounds so crazy. Can you imagine doing craniotomies for brain tumors? Now we have these magic treatments. So let me leave you with one last lesson. My last lesson for you is, in one slide, what is the secret for your success? How can you have a fantastic career, very fulfilling career, make a tremendous impact in your communities, publish many papers, and I've summarized all on one slide for you. So I would ask you all, especially the junior people, to pay particular attention to the slide. And the slide is, the secret of getting ahead is getting started. So that's my challenge to you. Get started, and I wish you well on your journey. Thank you very much.
Thank you.
Thank you, Professor Reisler. Andrew, thanks very much. Very excellent educational talk and motivational talk as well. You touched upon a number of aspects. I think a very important program which we're running is the concussion program. And of course, looking at the physical abuse, the shaken baby syndrome, I think is something very important which we're working on, really very commendable. Professor Reisler has been really pushing the neurotrauma committee to new heights and doing a lot of work in different fields, and I think that is very, very important. The inflammatory biomarkers, really, that is a very interesting topic, and it shows that, you know, the bench research can be very, very helpful in improving patient management, and I think that that's a very, very important task. And I think it would be a good idea, if you remember, there was a group headed by Professor Andrew Mass, and they did a big TBI program, and they had many centers in that. I think it might be an idea to see whether this can be made into an international study, really. So thank you very much. Any questions or any comments from us? Thank you.
Thank you. Thank you very much. We can invite comments or questions from the audience. If anyone wants to ask, we may just click on the raise your hand. In the meanwhile, my co-host Libun saying, any questions from you?
If I could just touch on one
Please.
comment that Professor Khan said, you know, traumatic brain injury, why is it so different? Why do some people do well, some people not so well? We all know that. And I think it speaks to the heterogeneity of traumatic brain injury. No two head injuries are the same. Professor Hutchinson gave a talk and gave a slide that looked like a bowl of spaghetti of all the different pathways that are affected in traumatic brain injury. The mitochondria, the vascular, the blood-brain barrier, and all are affected to different degrees. But I think a common pathway to all head injuries is this neuroinflammation. And I do believe it's going to give us some answer and some commonality on what happens in all head injuries. To a degree, there's going to be some degree of inflammation. And that may be a way to perhaps get a better handle on this problem. We found it, as I said, alluded to it in a very elevated in abusive head injury cases. Real briefly, I think the reason for that is that by the time we see these kids, it's not the first head injury that they've had. They've probably had some minor head injury before, never came to hospital. Only when they have a second, third, or fourth head injury do they come in. And of course, the inflammatory system has been overprimed by that point, and we get such high levels. Thank you.
Thank you very much. I would like to say that the newer marker that you showed, osteopontin, is a very interesting one, and we look forward to read that article shortly in the literature. Thank you very much for bringing it out. My co-host Liubun Singh, any comments from you?
Thanks, Raja. Thanks, Professor, for an exciting lecture, Professor. I have 3 questions, Professor. We still use Glasgow Coma Scale for head injury, but in my opinion, Glasgow Coma Scale only good for acute brain injury. What's your opinion regarding those with chronic brain injury, especially those abuse head injury pediatric cases? Do you think it's still reliable to use GCS? My second question, Professor, biomarker. For me, I think that biomarker useful for prognostication or stratification of patient. How do we use those biomarkers together with Glasgow Coma Scale? Whether we will upscale the injury from mild, moderate to high if those raise a biomarker. My last question, Professor, what's your opinion regarding neuroplasticity in pediatric? I used to have one child very young with hemisphere injury, paralyzed one side, but some years later, she able to walk. So what's your opinion compared to adult? Thank you, Professor.
Of course, no. 3 very good comments, and let me quickly jump in. The Glasgow Coma Score, it's the best we've got, but it's not perfect, especially for the young children. For example, as you know, there's a verbal component, and they've tried to modify it and done pediatric components, different ages, but it's very difficult and cumbersome. And there's a lot of inter-observer variability, firstly. Secondly, it's been the bane of our research. A person has a head injury, has a seizure, they come into the ER, they're post-ictal, they're going to be graded at a lower Glasgow Coma Score, which really reflects a seizure more than the head injury. So it's a difficult, cumbersome problem, but it's the best that we've got. It's universal, and I'll stop right there. The second part of your question, the outcome. We use actually a fairly good score. It's the extended Glasgow outcome score, a 8-tier score, good and bad, with in-betweens. My coworker, Dr. Blackwell, uses it for her long-term prognostication. I think the most important point you raised, and if I could just sort of emphasize this more than anything else, why are we using biomarkers? I mean, okay, the person's going to do well, not well, it's interesting, it's nice. Well, the 2 groups that Professor Khan alluded to, the major group in Europe, Center TBI, in North America, Track TBI, they are using that device to look at their marker that they found the most useful, GFAP. They have a device, much like an iStat, looking at glucose. in the helicopters going to get those people, get the injured patients. The military's using it. And it works both ways. As I'm sure you know, how many unnecessary, expensive transfers are made to your facility on people that fell, they're kind of unconscious, but really have got a normal scan with by the time they arrive. And if both the military situation, the civilian situation, if you could say your biomarker, whatever it is low, you've got a 99% chance of having a normal CT scan, you would avoid those unnecessary transfers. Also, the opposite side, if it's sky high, you'd get ready for surgery and you'd be better prepared. Another example, a big controversy, and I wrestle with this all the time. Kids come into the emergency room, they comatose, I get their scan. I'm guessing, do I do a invasive surgery that's got associated with side effect, with complications, like a massive decompressive cranie, open the dura, or do I wait till the ICPs get high? I don't think we have the right answer. And I'm hopeful. In fact, I believe fervently that a biomarker would answer those basic questions that we have at the bedside. So yes, you're right. A lot has been said about prognostication, how the patient's going to do. But like you, I'm a neurosurgeon. I want to know what to do in the emergency room. Should I jump in and operate on Johnny or Mary or whatever the patient's name is, or should I wait? And I have no doubt that the biomarkers will help me with that. The last question was neuroplasticity. Oh my gosh. Yep, you're right. That's why I'm a pediatric neurosurgeon. The kids make you look good, don't they? They, no matter how we operate and how much brain we take out, somehow they always make a better recovery than kids. And I'm thankful to them for that. And I'll stop right there. Thank you.
Thank you very much.
Including, by the way, I showed you one of the pictures of this horrendous looking gunshot wounds. I think it was case number 5. That child survived. It's got a little hemiparesis. That child survived. I didn't have time to say that. And I know if it was an adult, they would be dead for sure. Thank you.
Thank you.
Thank you. Thank you very much. If I'd like to ask Professor Reisner one question, that in these children, how do you evaluate the need for CT scans? Like how frequent are they in your institution? Because the follow-up of a severe head injury, that is very essential, and the question of radiation is always there. So what is your protocol?
Sure. 2 parts to that question. The severe head injury, we have a guideline. It's in the Journal of Neurosurgery. I'm happy to share it to everyone. Of patient comes in, does or does not have surgery. We put an ICP monitor or an EVD. You go through your algorithm, and at some point it branches off. If you have these spikes in ICP, they're not responding, you get CT scans, and that's sort of protocolized. We have in the protocol what we call quote unquote panic values. Kid blows their pupil, blood pressure goes up, heart rate drops, give a bolus of medications, quickly get a CAT scan to see if there's any surgical lesions. So that's a severe head injury one. On the more mild head injuries, really case to case, but generally, we absolutely try to avoid CAT scans as much as possible for reasons that you've just discussed. Not only the radiation, but also logistics. I mean, we just can't get a CAT scan on every kid that's got a concussion, and it turns out you don't have to. And so we reserve it just if there's obvious problems, such as a Glasgow coma score that goes from 15 to 14 to 13, absolutely. A CSF leak, otorrhea or rhinorrhea, signs of a basilar skull fracture, a cranial nerve palsy. I mean, they have to be hard and fast findings. And again, on our website, we have the indications for, the absolute indications to get a CAT scan. I understand it's easy to sit here and say that. There are some in-between cases, but generally, our trend is not to scan these children.
So with the inflammatory biomarkers, it might become a little more scientific to know that, okay, here's a child looks to be okay, but has high biomarkers, should do a scan, maybe.
Correct. That is our hope. Yeah.
Thank you very much. Yes, Professor Takashi Kon has joined us from Tokyo. Professor Kon.
Thank you, Dr. Andrew Reisner. I'm Dr. Takashi Kon from Tokyo, Japan. Very wonderful lecture, very interesting lecture, the biomarkers. I have one question about the head injury impact of biomarkers, relationship between the impact of head injury and biomarkers, because there are very head injuries are varied from motor vehicle accidents or gunshot wound or localized head injury or concussion, but diffuse brain injury and local brain injury is a very the impact of the brain and impact of head injury varied. So are there any difference between the biomarkers and the local point of brain, injured brain, or impact to the brain injury? Are there any relationships, the biomarkers?
An excellent question. We do not have that answer yet. We just don't. And I think that what you're speaking to is what I alluded to previously, the heterogeneity of head injuries. They're all grunt under trauma. And, you know, we divide in penetrating, non-penetrating. Well, I mean, that's really not much, is it? You take any category, let's take the blunt trauma, blunt trauma with brain swelling. You have two patients. I guarantee you the outcome is going to be different on both patients. No two patients are the same. And I think that that reflects, you know, on a very gross scale, what's going on a biochemical scale. And different pathways are going to be affected in different people, whether it's more hypoxic or less hypoxic or whatever the case is. I do think, Dr. Khan, you've got to look at commonalities. You know, some people have hypoxia, some people have seizures.
Yeah.
All of them are going to change it.
Yeah.
But the common thing is the brain responds to inflammation in kind of uniform way, we think. Further research may show no, there are different inflammatory pathways. But right now, it's a microglia, inflammation is set up. What we don't know is which is the best marker. Is it this fancy osteopontin that we stumbled across? There's an excellent paper from the TRACK TBI, the North American study, that actually showed just an ESR or CRP can predict outcome. So maybe we don't need this fancy, not commonly used biomarker. We'll see, and hopefully we can answer that in the next few years. But I can tell your questions are excellent, and unfortunately, my answers are not.
Very well. The time will
Thank you.
tell.
Yeah, expect to the future.
Thank you very much. We look into the future for such wonderful biomarkers to be developed and put into practice in the management of pediatric head injury. So thank you very much, Professor Reisner and Professor Tariq Khan, for this wonderful session, and we learned a lot. I would like to inform our viewers that the viewership suddenly jumped from 490 to 550 people who are live as of now on YouTube, Zoom, and WeChat channel. With that, we come to the conclusion of today's webinar, and I'll close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Florent Rosen and Professor Andrew Reisner, as well as the chairs, Professor Michihiro Kono and Professor Tariq Khan, for the time and support for the ACNS webinars. I would like to express my sincere gratitude to Professor Shubin for broadcasting this on the WeChat channel, and as I mentioned earlier, we have around 550 people who have joined us live on all the combined platforms. A special thanks to my co-host Lubun Singh for joining in today. Until we meet on next Wednesday, it is bye-bye from all of us. Thank you very much for joining.